For all of you guys who are residents, and I'm sure all of you are there when the CTs are getting acquired, and that's something that you should all have a habit of. I don't think you have a choice. You have to be there injecting contrast and monitoring the scans. So now take active interest in how the technicians are acquiring those. Most institutes have their protocols which are already set. So you just have to drop down in the menu and select it. But you want to know that what should be the timing of the contrast. So that's what this main, that's the main focus of this particular session, where we talk about the contrast timings and the main scans. I'm not going to be talking about MRI today because we have another class on basics of MR sequences, and there I'll talk about protocol. So just a CT, and contrast mainly. So I've divided this into first a general overview of the various abdominal scans, and then we go organ wise. What how do you tailor in liver, pancreas, adrenal, renal, and bowel imaging, and then in trauma, right? So that's how we shall be dividing this talk in. Very, very important. Okay, so this is the basic stuff, and I'll also share this PDF on the Telegram group because I feel that this is something that you should have handy. So there is nothing with copyright in this, so I'll share it so that you have these timings handy. And they ask you this a lot, in your junior residency about these timings. So this box actually is the summary of it all, and it took a lot of time to compile this. So this is something which is what you all need to essentially know, and then just different organs, which do you pick out of these is what I'm going to be telling about. Okay, so first of all, what is the coverage? That let's just address that. So that will depend on what kind of a scan we are doing. Unless mentioned otherwise, for an abdominal scan you will start above the dome of diaphragms to include the base of the liver, and you end below the ischial tuberosity, right? So this is what is the usual abdominal protocol. When you are doing a dedicated KUB scan, then we need not start from the dome of the diaphragm. You can start below the dome of diaphragm, right? So this is where you will usually start, just where the two diaphragm, you can see where the diaphragm begins. So that's where you're gonna take. So this is about the coverage that you have to decide on the topogram. Now let's start talking about the contrast. First of all, the rate at which you have to give contrast. So here we are assuming you are using any non-ionic contrast. Usually we use non-ionic monomer, that is iohexol. Some places do use Visipac, which is iodixonol, but almost everywhere iohexol is the contrast that is used, which is 350 mg per ml iodine, 350 mg iodine per ml, right? So that is the contrast density. So usually it is weight dependent, but in general, 100 cc contrast is what is injected. 120 cc, as the weight increases, you increase the contrast and you also increase the delay. So a general rough idea for heavier patients, above 75 kg, you want to increase the contrast amount by 20 to 30 ml, and you increase the delay by 5 to 7 seconds, because they tend to have more intravascular volume. So the contrast reaches the destination a bit later. So just two things that you keep at the back of your mind. Heavier patient hai, to time बढ़ा दो और amount बढ़ा दो, right? So that is about the contrast. The rate of contrast, if you are doing an injector contrast, which most of the places do, and especially when you want to get, arterial phases, you will use a power injector. So in that case, you would want an 18 gauge catheter minimum, and I hope you remember 18 is green signal at 18. So minimum green cannula हमें चाहिए for 5 cc per second का rate that you want to give ideally. If you have a 20 gauge is pink cannula, you want to give 3 to 4 cc, right? So depending on the cannula, if you have a blue cannula, don't go above 3 cc anytime, it will extravasate, okay? So in a blue cannula, you want to go to 2 to 3 cc per second. So this is the setting that you will put in your power injector. Fine. Bolus tracking ki baat karenge, but before that, what is the time, So what is the time? And this time refers to as soon as the contrast is injected, at what time do these phases occur? Okay, so we have now I'm telling you the most important part. Okay, so most of the masses we will want to take an NCCT unless you have a dual energy CT where you can acquire virtual non-contrast images. So NCCT can be done away with. After the contrast is injected, early arterial is what comes at 15 to 20 seconds. This is the phase which is your angiographic phase, right? So this is the main utility here, that it's only going to be the vessels which will have the contrast, and no parenchyma, no organ would have received the contrast by 15 to 20 seconds. So this is done where all? So we want to do an early arterial whenever we have a case of abdominal trauma to rule out vascular injury. Any indication of mesenteric ischemia, yes, we want to do early arterial phase. Where else do we want to do early arterial phase? That's it, right? So as far as abdomen is concerned, mesenteric ischemia or trauma are the only two indications where we'll acquire an early arterial. Then comes the late arterial. So सेम टाइमिंग बट टू नेम्स. सो लेट आर्टीरियल फेज हमारे लिए सबसे इंपॉर्टेंट कहाँ है? टेल मी विच इज द मोस्ट इंपॉर्टेंट प्लेस वेयर विल कीप टॉकिंग अबाउट लेट आर्टीरियल फेज. लिवर, करेक्ट. सो इन लिवर इमेजिंग वी वांट टू डू लेट आर्टीरियल फेज. या, सो दैट्स व्हाट इज द मोस्ट इंपॉर्टेंट. यस, फॉर पैनक्रियाज एज वेल, but for pancreas late arterial is not a game changer. That is for the extent agar CA pancreas hai to again we want to do a pancreatic phase there. Okay, so that's going to be a little more delayed. Yeah, so yeah, hypervascular masses in the pancreas for sure. Okay, so late arterial phase in the kidney we call it corticomedullary phase. So corticomedullary phase in the kidney, again it's to pick up hypervascular masses, right? Which is usually a clear cell RCC or an angiomyolipoma. So corticomedullary for hypervascular, and late arterial essentially to pick up hypervascular masses of the liver also. Yeah, so hypervascular in liver and kidney. And we will talk about what all are hypervascular masses in the liver. Essentially three. What are the three main hypervascular masses in the liver? One obviously is HCC that we want to pick up as late arterial enhancing. Tell me two more DDs. One which will show arterial enhancement, but then it becomes almost isodense to the liver parenchyma. That's FNH, right? So FNH is also an arterial enhancing lesion. Intrahepatic cholangio, typically we call it hypovascular because it's delayed, right? It'll slowly pick up enhancement. And then can I say hypervascular metastasis? So by the traditional definition, these three are what are called as hypervascular masses. So you want to pick up their enhancement in the arterial phase. Okay, so this is late arterial, which is 35 to 40 seconds. By this point, we will not see the portal vein enhancing, but we will see the parenchymal enhancement. Now we go to a phase which is very forgiving, which is the venous phase, which goes on for a long time, from 50 to 100 seconds. So जो हम usually करते हैं, when we don't want to do arterial and we're doing a hand injection, then it's very forgiving, है ना? हम तो आराम से कभी आते हैं, कभी भाग के आते हैं. So this is where you have a window from 50 seconds till 100 seconds. कभी भी ले लो, you will get a good venous phase, right? So bowel का particular enteric phase is defined as 50 to 60 seconds. One phase we forgot in between is just after late arterial, which is the pancreatic phase. So pancreatic phase is almost 40 to 50 seconds, right? So just in between these two. So pancreatic is 40 to 50, and then you have the enteric phase. फिर आ जाता है हमारा venous, traditional venous or portovenous phase, which is 60 to 70 seconds. Then we have the nephrogenic phase. So again, relevant for the kidney, renal masses. So here only hypervascular masses will be seen, and you'll have a very good corticomedullary differentiation. But in this, you will miss out on hypovascular masses of the kidney. So hypovascular and all other masses of the kidney are best seen in this phase. Okay, so this is where you have 100 second pe best for renal masses, where they stand out from rest of the kidney. Cortex and medulla now look the same. Okay, so this is nephrogenic phase. Then we do a delayed phase for almost all liver masses, which is ideally 3 minutes, but 3 to 5 minutes. And why do we do this? This is to see retention of contrast, right? So retention of contrast, very good, tells us about fibrous tissue, isn't it? So this, if I see enhancement which is persisting in the central scar of a mass, what do I think of? We think of FNH, right? That FNH का scar will retain contrast. If I see that there is a mass जो periphery में enhance कर रहा था arterial venous में, and it's retaining contrast till 3 minutes in the center of the mass, very good. That is intrahepatic cholangiocarcinoma, right? So that is what is the role of the delayed phase, to show us whether there is fibrous trauma or not. Hemangioma also will always match the blood pool, so that's the utility. We compare it with blood pool again. Yeah, or yeah, even sclerosed hemangiomas. You can say that. So if there is a sclerosed